Welcome to AmeriCare's Healthcare for All Universal Health Coverage Day event. I'm Dr. Rashad Massoud, AmeriCare's Senior Vice President and Chief Program Officer. AmeriCare has been saving lives and improving health for more than 40 years. Our programs are uniquely designed to improve the health of people affected by poverty or disaster. By supporting over 4,000 health centers worldwide, with transformative health projects and donations of medicines, AmeriCare improves the health of millions of people in need every year. Health is at the center of everything we do here at AmeriCare, which is why we are excited to host this Universal Health Coverage Day panel discussion. It's fitting that today's event coincides not only with Universal Health Coverage Day on Sunday, but also Human Rights Day today, because health is a human right. Universal health coverage is a global movement working towards a world where everyone is entitled to the health services they need without financial hardship. The goal is to make healthcare more accessible, more equitable, and more affordable by improving how it is financed and delivered. Universal Health Coverage Day is a time to amplify the importance of universal health coverage as a priority for international development. Universal health coverage will help us achieve the Sustainable Development Goals for ensuring healthy lives and promoting well-being and reducing poverty. According to the World Health Organization, universal health coverage will be achieved when all individuals and communities have access to the full spectrum of quality health services, including disease prevention, treatment, rehabilitation, and palliative care. And that includes access to vaccines and medicines. There is no one-size-fits-all approach. Some countries provide national, government-funded health programs financed by taxation. Others have national health insurance programs financed by user fees. And it's not just for wealthy countries. Over 100 low and middle income countries have taken steps towards delivering universal health coverage. Today, we will be discussing how to make good healthcare attainable for everybody, so people can attend work, school, contribute to strong communities, and lift families out of poverty. We have four fantastic panelists with us today, all global health experts who bring unique perspectives. I will introduce each one of them as we go so you can hear more about their experiences and how it has shaped their views on this critical issue. We are going to have time for questions at the end. You can add your questions in the Q&A at any time. And with that, let's get started. Now it's my pleasure to introduce our first panelist, Dr. Tamar Chilidze. Dr. Chilidze has over 20 years of experience in global health, academia, government, and the private sector. She's an advocate for international cooperation and partnership to further medical knowledge, prevent disease, and increase health access and delivery. Among her many accomplishments was leading the charge for the United Nations Universal Health Coverage Political Declaration in 2019. Welcome, Tamar.
Thank you so much, Rashad, for the very generous introduction. And thank you also, fellow panelists and all of the participants. I'm truly honored to be here today on this super important topic that helps us raise awareness and ensure that we truly leave no one behind. So thank you. I'm glad to be here.
Thank you for being here. Tamar, you've been a proponent of universal health coverage for more than a decade. Can you tell me, what does universal health coverage really mean, and what does it look like in countries that have adopted it? And what does adoption mean? Does it mean that every country that declared commitment is implementing it now?
Right. It will not maybe a very short answer. So it's quite a number of questions here. UHC really means, and you said it also, Rashad, that all individuals and communities receive the health services that they need without suffering any financial hardship. And we all know by now that the health is a human right. And you said that we are born with this right, and we are all entitled to have access to services, medicines, vaccines at the time when we need them. And when people receiving any of those services, they should not really experience any catastrophic expenditure, driving them into the poverty. So it really covers the spectrum of all of the services, from promotion to prevention, treatment, rehabilitation, and palliative care across the life course. And I always like to use actually acronym to describe it in a short way, and that's AAA plus S, which stands for available, affordable, accessible, and sustainable. Because if we take any of those out, if something is available but it's not affordable or accessible, or most importantly sustainable, then it's, and vice versa. So we can play with those words and really answer the question. So it has to be all of the three and also sustainable. And very importantly, also to emphasize that UHC really does not mean that the services or medicines are free of charge. It doesn't also mean that financing, for example, healthcare will ensure that we have the UHC. So that's because oftentimes actually, people may think that, oh, it's all about insurance or it's all about the financing and all of those. So that's something to really keep in mind. I think your next question was, what does it really look like in the countries that have adopted? And every country is very different. Like you said, there is no size like fits all. It's different how they have or implement it. And it largely based, number one, is the political will and how they approached or will approach and identify gaps and challenges. We also need to realize that there is no easy and quick process, and it requires really long-term commitment and dedication. For example, how much GDP, and I have highlighted earlier, is spent on healthcare is not a guarantee of success. So meaning, how much financing is involved, it's not the only determinant for the UHC. For example, like countries like Singapore, they spend under 5% of their GDP on health, and yet they are the shining examples of success. And the countries that are spending, for example, over 7%, they are not as successful as, for example, Singapore. In Singapore, government keeps healthcare costs very low and then uses those low costs to make market-driven insurance system possible. But for example, that type of approach may not work in other countries where healthcare cost is high or the systems are failing. And when I say systems, I mean, whole spectrum again, like healthcare delivery, financing, human resources, governance, etc. On the other hand, like Japan, who is champion not only because that they have great system in place, but they are the biggest advocates for UHC around the world. And in Japan, they have both. The healthcare is universal and it's also low cost. It also very uniformed and equitable, providing equal medical services for all people, regardless of person's income. The other example comes to my mind is Brazil also. Brazil is one of the oldest countries with universal health coverage in place, and it is actually part of their constitution, meaning that the Constitution of Brazil defines that health as a universal right and it's a state responsibility. And just to summarize that particular country examples, the UHC implementation is quite different, but main message for all of the governments is that no matter what they need to improve or strengthen, they should really work towards accelerating implementation and ensuring that people have access to quality services, vaccines, and medicines at the time when they need it. And now that the world is focused on COVID-19, it's even more important, right? To have this holistic approach to health, keeping the current pandemic in perspective with other diseases, so we do not really lose the progress. Because if we had, for example, UHC by now, we would witness fewer human sufferings, much less unpleasant endpoints, the not as growing burden of other diseases, and economies also would suffer so much less, and so on. So the list could be really very, very big. And like again, I will bring Brazil's example that has the UHC in place. They faced a lot of challenges following one of the world's actually worst COVID outbreaks in the area, unfortunately. And I think you also asked me, the third one was what does really adoption mean, and really ties to everything that we are discussing. It means that the countries that signed on to me, because I was also on the political declaration as one of the officers, to me, it means that the countries that signed on, they are in the process of accelerating the progress. To me, it means that they have actually promised us, and now I'm in anticipation along with all of the people, that the steps are taken, and steps are taken also in a very I'm getting also a bit emotional here, but you know, because of the COVID interference and all of this, I know it's hard, but we're all taking steps towards, you know, doing and implementing UHC everywhere. And that includes the financial risk protection for the governments and access for the people to essential healthcare services. Again, I will bring my AAA+S, so it's back of their minds. And the good news is that many countries are already making progress. Although COVID-19 pandemic really impacted that. But that being said, so job is not done, but hopefully will be done in the very near future. And we will see UHC in all of the countries, so no one is left behind.
Mar, thank you. Every time I hear you speak about this, your passion comes through and I learn something new. Thank you very much for that response. If I can now go on to the next question, and here I am pleased to welcome Dr. Shams Sayed. Dr. Sayed is the World Health Organization's head of unit for quality of care. Amongst his many responsibilities is overseeing the World Health Organization's National Quality Policy and Strategy Initiative and WHO's technical work on quality in fragile, conflict-affected, and vulnerable settings. Throughout his successful career, Dr. Sayed has worked with over 30 countries and has taught at the university level. Welcome, Shams. If I can ask you, well, please go ahead, say a couple of words before I ask you a question.
No, Rashad, thank you so much. And it's a pleasure to be with you and fellow panelists today. Looking forward to the discussion.
Wonderful, great to have you with us. Shams, if I can ask you the question, why is quality of care so important to consider when moving forward with universal health coverage globally?
Yeah. Thanks for that question, Rashad. And some of this will actually build on the points that Tamar just described. Universal health coverage, the concept of universal health coverage has quality firmly embedded within its fabric. So as you actually described in your introductory framing, universal health coverage includes financial risk protection, but access to quality essential healthcare services. And that's a fundamentally important point. Access and quality come hand in hand. So access without quality is perhaps an empty promise to populations across the world. And when the magic of access and quality comes together, then it's a potential realization of the principles of universal health coverage. And particularly given the global pool of knowledge related to mortality attributable to access issues and quality issues, we recognize now, and this came forth very clearly in the Lancet Commission's work a couple of years ago, and the WHO, World Bank, OECD report on the subject, as well as the US National Academies of Science, is that we now know that in the majority of countries, quality issues are responsible for the majority of mortality associated with lack of universal health coverage. So here we're highlighting that access and quality are key and they come hand in hand. And it's not just in countries that are stable, but also when we talk about quality of care in fragility, in conflict, and in vulnerability, we need to keep that lens of universality and universal health coverage within the dialogue there, recognizing that 2 billion people on the planet are living in conditions of fragility, conflict, and vulnerability. Just in a few words, our key points of emphasis, Rashad. One of the things that we would also always emphasize is that it is really important to look at the different domains of quality: clinical effectiveness, people-centeredness, patient safety, timeliness, equity, efficiency, integration. And these domains allow us to create a compass around health services that helps countries to define their pathways. And when countries, and as Tamar has highlighted, define their packages of health services, our intention should be for the delivery of those health services with quality embedded within that thinking. National level decision-making and district level implementation, all the way to facility level delivery of those high quality services. And that's not just a rhetorical piece, it's really something that's at the heart of delivery, because every patient or every person encountering the service will want for their child or for their mother the highest quality of services that is possible. And that, in my mind, is at the heart of universal health coverage. Rashad.
Thank you so much, Shams. That's a wonderful way of explaining it. If I may now go on to the next question, and here I would like to welcome Dr. Ambrasi Edward. Dr. Edward is an associate scientist at Johns Hopkins Bloomberg School of Public Health within the Department of International Health. She has performed extensive research on health systems and community-oriented healthcare in low and middle income countries and fragile states, and has worked on contracted projects for the World Bank, the U.S. Agency for International Development, DFID, and numerous other organizations throughout her distinguished career. Ambrasi, welcome.
Thanks very much, Rashad. I'm excited to see this reversal of roles where you engage in the quality management course at Hopkins, and now we engage collectively. I'm glad to see this very distinguished and expert panel that I'm looking forward to learning from.
Thank you, Ambrasi. Always a pleasure. Quality, as we've discussed, is essential, but so is access for those who are least able to afford health services. Now, you've worked extensively in resource-constrained settings. How can we design patient-centered universal health coverage for those who can't afford premiums for health insurance?
Well, Rashad, I'm sure our panelists and Zoom audience are familiar with some of the projections, but just to reiterate, based on current trends, WHO estimates that 5 billion will still be unable to access healthcare in 2030, and now 90 million are impoverished by health expenses every year. In the developing countries, $500 billion are spent annually, and most of this is out-of-pocket expenditures with more than $80 per person. 6 years ago, the World Bank also produced a report on how 24 developing countries are implementing UHC reforms from the bottom up. They provide some key insights and how to address the inequalities for the poor and vulnerable, confronting financing and the provision gap, as Tamar mentioned, to ensure effective coverage. But the poor still receive substandard care as they can't afford the premiums, as both Shams and Tamar mentioned. For social health insurance, they don't have access to the same type of providers, competent quality providers, and they can't afford the medical supplies or costs of transport. And sometimes they belong to ethnic minorities and often discriminated when they seek care. The dual systems that have been proposed with a contributory path for social health insurance and non-contributory path for also require tax and health reforms. But the geographic targeting also has significant cost and administrative implications for identifying the poorest and the vulnerable and targeting these services. And we also need to think of universal health coverage beyond primary health care for the poorest, because as we are seeing, there's been enormous trends in highlighting the disease burden for non-communicable diseases, even in the poorest socioeconomic strata. So this is something that we need to be considering in the future and how we're going to be integrating care. However, most of these are still a top-down approach, and it does not factor people and communities as co-producers of healthcare. In high-income economies, we integrate value-based healthcare with patient-reported outcome measures, patient-centered care, but we need to focus more on patient-centric care. We've tried to engage community health workers, and they have addressed the issue of coverage to some extent and patient-centered care, but this doesn't fully integrate patients or communities in the dialogue. As William Osler, one of the big four from Hopkins, used to say, it is much more important to know what sort of a patient has a disease than what sort of a disease the patient has. In an era we are attempting to decolonize healthcare, empowering the patient and communities with client voice, community scorecards, and other social audit mechanisms to create awareness of their entitlements, access to information, is critical to co-create and determine what services are required and the service delivery architecture. When we were in Afghanistan conducting national performance assessments on health service delivery, we used the balanced scorecard, but yet the real empowerment was evident in the experiments we conducted on community scorecards, where people and communities were engaged in how healthcare was designed, in the delivery of healthcare, in the scoring of performance, and most importantly, the joint decisions that were made with the healthcare providers and how quality of care can be improved. So my clarion call, as many in this audience, is to focus on the bottom-up approaches on how we empower communities and people to define and address and access healthcare. Thank you.
Thanks, Ambracia. And I imagine this is going to be a journey.
I believe so.
Yeah, with a lot of learning. If I can now ask the next question, and here I would like to introduce Professor Michael Marks. Professor Marks is an expert in international public health at the Heidelberg Institute of Global Health in Germany. He's a medical doctor specializing in internal medicine, tropical medicine, and public health. He has more than 30 years of experience in health systems development and research, health program management, evaluation, and research. Welcome, Michael.
Thank you very much, Rashad. Thank you very much for having me with you. I'm very glad. Also, thank you to the panelists.
Michael, it's great to have you and to re-engage despite the pandemic. Michael, we're in an era of e-health. How does digitalization in health impact universal health coverage?
Yeah, thank you very much for this question. I think universal health coverage is now a key topic in international health, and digital health, or e-health, some call it e-health, is somehow cross-cutting the health system. And it bears a huge potential in improving also issues of quality, issues of patient safety. And we could also derive the different aspects of digitalization from the objectives of universal health coverage. And I mean, the previous speakers, they have already stressed some of the key issues or key points in universal health coverage. That is equity also in health service utilization. That is, of course, the access to essential health services. That is also financial risk protection, and also access to medicines and as I said already, to essential health services. So there are strong arguments for having both health and digital in all policies. However, the sobering statistic is that in the public sector, for instance, digital technology projects at best only 20% succeed. So now let's have a look at the potential and the impact. So it's not replacing what we have, but it's rather changing the way we think. That is about digitalization. And as I said already, it is cross-cutting the health system, the different building blocks, and all the different domains that were already mentioned before. So if we look at the provider's perspective, there is at the level of, first of all, a health information system that is quite obvious. So it's about improving health provider payment system. It helps also to better allocate the workforce. It is, of course, it has a potential to better assess and better process and analyze health data. But also, if we have to look also at the other side, at the client side, for instance, especially for clients who are living in remote areas, for instance, we have enormous problems really to reach them or to reach out. And they have, of course, they have difficulties with access. We all know that. So first of all, with digitalization, we could tremendously improve access to information also, and also access to better care. It could also help to come to informed decision-making also at the side of the patients. And on the other side, if we look at the provider side again, so it is, we could certainly steer much better the patients, so to ensure that the right client gets the services entitled to. Doing that, we could enormously better also the efficiency of our system, to avoid duplication, for instance, of services, and also the actual decision-making could be much improved. We could, on the provider side, we could introduce telemedicine, for instance, also again for remote health facilities, for providers working in remote areas, for instance. Telemedicine bears a lot of potential to have or to provide access to specialized care, for instance, or specialized diagnostic services. The medical imaging is one example, what that could be named. When it comes then to capacity building, also virtual peer-to-peer supervision could be mentioned, or also digital training. I think that has really proven its how shall I say, its importance now during our pandemic, the COVID pandemic. So that is, these are just some aspects where digitalization in health could really improve not only the physical access, but it could improve tremendously quality of care and also the patient safety.
Thank you, Michael. And if I can just ask you a follow-up question, what are some of the stumbling blocks to integrating digital health into systems? And what has been the effect of the COVID pandemic in overcoming some of these stumbling blocks?
Well, I mean, that has a lot to do with the way digitalization is used so far. I mean, there's a great openness. Everybody is now more than ever convinced of the place of digitalization in health system development. I mean, there's no question. But it's, on the other hand, it's quite difficult to really define the boundaries and to introduce clear rules. And because it has a lot of issues, ethical issues, for instance. And we have also, it has security issues, data security. I mean, that's also ethical if you want. So, these are important issues, important stumbling blocks also, because everybody is now doing something in digital health. But the question would be how to harmonize it and how to integrate digital health, digital solutions into a comprehensive, but also a very adapted health systems development, because systems are not equal. I mean, we have really to look into the reality of the ground. We have this another important issue is the issue of interoperability of solutions. I mean, we have the tendency to really look rather for technical solutions than into processes, and this is also a problem in digitalization. Yeah, we are very much very much in favor also of nice technical solutions. But I mean, we should also think of the processes, how to use these solutions in real life, in the reality of the field, of the health workers. And digitalization should really be, should help really better do the job. And it should not necessarily replace jobs, but of course it could alleviate also the heavy workload of health workers, for instance. So the question of data ownership is also quite important. Who owns the data? And this has also legal implications. And increasingly also this is being addressed also in low and middle income countries. I mean, in northern countries, I mean, there is already a legal framework in place, but I mean, that is also something in process. And if I look into Germany, I mean, we are not the champions in digitalization, I must say. But so we have a lot to do in that respect.
Thank you, Michael. That's amazing to sort of see and then see the difference as well. Thank you for that. Shams, can I ask you another question? There's another trend that we're seeing globally, and it's an emphasis on compassion as part of quality care. Why is this important, and how does it impact universal health coverage?
Thanks for that, Rashad. And I think let's come back to the world that we're living in today. So when we think about UHC Day coming up, what's the UHC Day theme? It's health for all, protect everyone, and investing in health systems is what can protect us all. But if we're looking at health systems, we have to consider the people within the health system, but also those that are served by the health system. And in many ways, this is where the element of compassion comes in. When we think about compassion, what are we talking about? We're talking about an equation that emphasizes awareness of suffering, empathy, and the associated action. So 3 elements: awareness, empathy, and action. That action part of this equation really changes the dynamic of just thinking about somebody suffering or feeling, but there has to be some action. And that's where the linkage with quality is very clear. Within the context of the COVID-19 pandemic, clearly that has become at the forefront of services and systems across the world. The compassion that is placed between the health worker and the receiver of care, the compassion that exists between community members, but also the compassion that we bestow upon those that are serving us, the health workers across the world that have sacrificed so much. How are we compassionate towards them? But how are they compassionate towards each other? And then finally, also thinking about compassion as a lens for decision-making. How are decisions being made at different levels of the system, and how is compassion influencing those decisions? So a multi-layered process, Rashad, but thinking about compassion at all of those levels has an influence on the quality of care that is provided to human beings across the world.
Great. Shams, just, what are the top things that come to your mind about how do we embed compassion and quality into the drive for universal health coverage? What would you think of right away?
Big question. If we're thinking about how quality can be embedded within universal health coverage, let's take the quality question. One is it's already embedded within the fabric of universal health coverage. So that's just recognizing that and always highlighting it's not a battle between access and quality. It's access and quality to maximize health impacts. And also emphasizing that when countries are setting their national strategic direction on quality of care and services, making that a key pillar of universal health coverage efforts is key. And the primary healthcare approach is the driver. Placing quality within the primary healthcare approach, ensuring that we are really emphasizing the overall approach to primary healthcare, not just about primary care services, but thinking about public health functions, thinking about engagement and empowerment of communities, thinking about governance arrangements. All of that is placed within a primary healthcare approach that's been articulated at Astana and that has followed decades of work on primary healthcare. Compassion is at the heart of the primary healthcare approach. And that's how those considerations can be embedded within our drive towards universal health coverage, recognizing it doesn't happen overnight, but the need is urgent, and the need is urgent in the places that are suffering the most. And that's where the compassion piece comes back in again.
Great, thank you. Ambrasi, can I go back to you and ask you about this new movement that we're seeing towards integrated care, where providers care for both the physical and mental needs of their patients? And considering that we have a global health work shortage, especially a shortage of mental health providers who can treat these disorders, Can we have integrated care with universal health coverage? What do you think?
Yes, Rashad, it is a complex problem to consider with the chronic workforce deficits that we are witnessing globally. Mental health is often overlooked, and it's also an important element of universal health coverage, as it's critical for people to lead a productive life. Both mental, neurological, and substance abuse are associated with significant premature mortality, and they impose a huge toll on human, social, and economic aspects. The statistics are staggering for mental health disorders, as it's estimated that nearly 1 billion are living with at least one mental health disorder, and every 40 seconds, a person commits suicide somewhere in the world. It's even worse with low and middle income countries, as I always focus on the bottom up. 75% of the people do not receive treatment, even if they're diagnosed with a disorder. And approximately half of these disorders emerge at the age of 14. And an estimated 20% of children and adolescents have some type of mental disorder, which is really staggering. And this is even worse with countries that are affected by conflict and violence. More than 1 in 5 people, which is about 22%, suffer from some mental health disorder. And of course, we have economic output losses, but I won't go there. To fully realize the goal of universal health coverage, we need to also consider human capital outcomes across the world. Mental health ought to be integrated with service delivery, not just at the primary healthcare facility level, but at the community level. And it must be covered under financial risk protection arrangements as well. Going back to the original question of workforce deficits, it still looms large in supply issues. Only 25 countries met the target, according to the Mental Health Atlas, for integrating mental health in primary healthcare. The global median number has increased from 9 workers from 2014 to 13 workers per 100,000 population in 2020. But there's also a high variation between high income countries, and it's 40 times higher than in low middle income countries. So this is something we need to be looking at in the future. So improvements in mental health promotion and prevention, it increased from 41% to 52% in 2020, but 31% of these reported programs didn't have dedicated human and financial resources, and 27% didn't have a defined plan. 39% had no documented evidence of progress or impact. And the COVID pandemic, of course, as Shams pointed out, and others too, has caused a global increase in mental health disorders with anxiety, lockdown, and I'm sure all of us have experienced this to some extent. And it also disrupts and even halts critical mental health services in 93% of the countries globally. So it's imperative we consider the engagement of the marketplace, as we witnessed with Ebola, with mullahs and pastors, churches and mosques and schools, to increase and consider how we can cover mental health preventive care. So engagement of lay providers, civil societies who are trusted, especially with religious leaders who are perceived as compassionate caregivers. We need to find strategies of effectively leveraging these non-health providers and training them in basic screening, counseling, referral, and to achieve the coverage we aspire. We're always focused on the health system and healthcare providers, but we need to be focusing on a more extensive people-centered approach to make them aware of health issues and be engaged in preventive mental health.
Yeah, Ambrasi, wonderful. My next question, I'm going to ask both Tamar and Michael. So maybe Tamar, you could start, and Michael, you could complement the answer. What would be considered success for universal health coverage? How would we measure that success? So Please, Tamar, if you'd like to take a go at that, and then Michael perhaps add to it. You're on mute, Tamar.
I am so sorry. I don't know. It's
Don't worry.
we are in Zoom world. So yeah, thank you, Rashad. And I would really like to thank the panelists, because I also took such a great and important points as we're discussing this this topic. So in terms of the success, but I actually start answering from second question, because I think this is how we can, go towards the success as how we can really measure it. And one of the things I want to share is that political declaration that, if not all, most of the countries signed on and promised us that they will accelerate universal health coverage, includes the targets. Even though the declaration is not too long, and we did it very intentionally. We wanted it to be an ambitious document that leaders could take home and act upon it, but we also ensured that the declaration includes the targets. So we have national targets as well as global targets. So for national targets, it says that we need to optimize budgetary allocation, not we, but the country's allocation on health, broaden fiscal space, and prioritize health in public spending. And as Sham emphasized, that we need to put a lot of emphasis on primary health care and targeting of additional 1% of GDP or more, based on the needs and the gaps that the countries will identify. Now, in terms of the global targets, it says that we need to progressively cover all people by 2030. We also need to reverse the trend of catastrophic health expenditure to eliminate impoverishment by 2030. And very importantly, also to address the shortfall of about 18 million health workers. We also need to create, and it's one of the targets, create additional 40 million health workers job by 2030. I think, by looking on those targets and going back to see, what we have achieved, we could, really see, how quickly or how effectively we are progressing. So to answer the question, what the success is, it is the paradigm shift versus incremental advancement. As we witness them promising us now the universal health coverage for all the governments of each country, now they need to really identify what the gaps are, because it's no size fits all. Again, Rashad, as you said initially, they need to identify the gaps, prioritize, make strategic plans, and very importantly, close the sectors, because it's not only the health ministers or health minister's job or only prime minister's assignment, it's everyone's assignment within the government. So it has to be, worked as a team. And of course, political will should, always remain, but action is most important. So I would consider success if I see political will backed up by action, to close the gaps and to ensure that those targets that are identified in our political declaration are truly met. And some of the countries cannot do it alone nationally, for example, and they also need the global support. So collaboration within the country, across the globe, and kind of, feel of the accountability and ownership for everybody, that this is something that we're all entitled, and we should really ensure that no one is suffering because they cannot access either services, medicines, or vaccines, and the quality ones, of course, it should be high quality always.
Thank you, Tamar. Michael, any other thoughts on that?
Yes, thank you. I think Tamara has outlined very well also the different levels of measurement. I would perhaps add some aspects going down the line of measurement, because I mean we have at the global side, at the national level, we have nice indicators. Yeah, we can measure universal coverage. There are indicators there. But I think it's interesting for all countries really to going down really the health service, the different health service levels, and measuring the indicators at the facility level. And then it comes back finally to the question of quality of care. And so, and Shams mentioned primary care, primary health care as a feasible or as a workable framework, for instance, and that could be nicely used really to check the different domains of your health system, and to measure the respective indicators. I think this is something interesting. And in that respect also, I mean, here comes in also digitalization that may also help really improve measurement and finally also bettering the quality of care.
Thank you, Michael. Well, now I want to ask all four of you a question. At the beginning, I said that AmeriCares believes that health is a human right. In your opinion, each one of you, do you think there's a difference between universal health coverage and health as a human right? Maybe I'll start with Ambrasi.
That's a tricky question, because if we define health as a human right, then we need to define health. And if we define universal health coverage, we need to define what the package entails and for whom. So I think the framework of how we phrase this, the devil's in the details and not the definitions. As Shams pointed out and has provided many illustrative resources from WHO, we need to be teasing out the details of how this should be reached to everyone effectively in a quality manner. So effective coverage for the services they require, not all services, but the ones that they require. So the definitions are important.
Thank you. That's a great way to look at it. Shams, maybe your thoughts on this?
Yeah, building on Ambrasi, complex question, and certainly definitional issues abound. One thing that I would highlight is the indivisibility of the Sustainable Development Goals and universal health coverage, just reminding ourselves that it's placed within the frame of reference of the Sustainable Development overall. And universal health coverage implies that all people will have access without discrimination, right? So there is that element of clear universality implied by the word, but this, when it's taken into the arena of the interdependent Sustainable Development Goals, provides us with a little bit more than just focusing in on healthcare or health services. And it's related to health and well-being in its broader sense. And that's where the health and human right connection comes in strong. So the linkages with poverty eradication, the linkages with education, the linkages with decent work, they are clear and they are profound. So this is where the linkages come in, but of course, there are details to be examined there. And it goes all the way to linkages with things like digital health that Michael was highlighting. There are specific linkages on the health and human rights lens that one has to consider, even when thinking about the application of digital health in healthcare and health services. It's a fascinating question, but probably a day-long seminar required for this one, Rashad.
So maybe that's something we'll arrange later on. Thank you, Shams. Michael, any thoughts on this?
Well, I mean, as you also said, it's a tricky question, and it shouldn't remain a philosophical one. I mean, I think with the concept of universal health coverage, the international community tried really to make a policy operational, yeah, to make it really tangible and being able really to follow it up and to measure it and to evaluating it. And so in that respect, I mean, it's something which pleases the practitioners, for instance, and it goes on the other hand, I mean, the human rights concept that has a lot of implications and which is difficult really to elaborate on during our discussion here, and that would, as you said already, that would require really another at least another seminar. But what I like with the universal health coverage concept is really that you can really bring it down to the operational level, and that is the big advantage, and you can measure it. And yeah, you know, if you can't measure it, you can't change it.
Thank you. Tamar, last word.
Yeah, I'll be very quick because it was very well said. I just built, you know, on the previous points that definitely it's a very complicated topic, and there is a lot, you know, to be considered here. But definitely, health is the human right, and universal health coverage, as Shams also said, it can be viewed as an umbrella that oversees all of those, you know, goals across the agenda, and you know, delivering on each of the pieces that ties back to the, you know, human rights elements. So it's really very much connected. So I think yes, but as everyone said, we do need, like, you know, half-day discussion, if not full-day discussion on this one.
Sure. Well, thank you very much. And I'm sorry that I posed a very tricky question at the end, but certainly, you know, as somebody who just over a year ago was looking at AmeriCares, and I'm a firm believer in universal health coverage. I'm a supporter. I've been working in this direction. And when I look at an organization that says, we believe health is a human right, for me, that makes me feel this is the place. And certainly, as much as I can see differences, and of course, there's a lot of philosophical debate that can go into this, I just feel that there is also much more alignment. So the commonalities between the two ideas are far greater than any differences that we can have. And of course, the devil is always in the details. I know we're coming up to the end, and I'd like to just sort of thank you all. It's really wonderful to have this conversation, to make sure that we are convening for Universal Health Coverage Day. We are keeping the movement, or contributing to keeping this movement alive, and for, you know, sharing with our colleagues and friends all of the things that we care about in this work. I want to say that I hope that next time we convene, we'll be able to convene in person as we used to in the old times. And you know, as great as Zoom is, it does you know, lose that personal touch that we used to have. So look forward to that. With this, I want to thank you very much on behalf of myself. I want to thank you on behalf of AmeriCares for joining us, and look forward to our future collaboration together, and also for all of our contributions towards universal health coverage and health as a human right. Thank you all very much.
Thank you, Rashad.
Thanks very much, Rashad.
Bye. All the best.
Bye.
Thank
Bye-bye.
you. Thank you. Bye-bye.
Everybody.